right, good morning. This meeting of the Texas Opioid Abatement Fund Council will come to order at 4:01 a.m. Tuesday, December 9th, 2025. Pursuant to the notice of public meeting, it's filed with and posted by the Office of the Secretary of State on Wednesday, November 19th, 2025. The council will consider only those matters that have been posted. Slides will be displayed during the WebEx meeting indicating the topic under discussion. The meeting materials are now available on our website. There are some hard copies here in the room, and we can also provide them via email after the meeting. Members, you must have your camera on and audio working when you are speaking. We also ask that those of you in the room identify yourselves before speaking so that the online audience can follow along. Those on the WebEx, please feel free to use the hand raise function. Votes will be taken with a voice vote today. Each of you is integral to this process, so please keep your camera on and be ready to unmute yourself when it comes time to vote. If we lose our WebEx connection for some reason and are unable to restore it, we will end the meeting and notify the members via email. Now I ask Katie, Director of the OAFC, to call the roll.
Associate Deputy Controller Rob Coleman.
Present.
Dr. Demore. Dr. Eloise.
Present.
Detective Enriquez.
Present.
Dr. Feno.
Present.
Dr. Fernandez.
Present.
Dr. Guevara. Dr. Kivala.
Present.
Dr. Mills.
Present.
Dr. Milton.
Present.
Dr. Thornton.
Present.
Dr. Wilkes. Ms. Yoder. Present.
Right, there being 10 council members present, a quorum is established. Members, thank you for your attendance today. I'm Rob Coleman, Associate Deputy Comptroller. Acting Comptroller Hancock designated me to serve as the presiding officer today, when he was unfortunately not able to be here. He sends his regards. I would like to take a moment and introduce Deputy Comptroller Lisa Craven. She wanted to drop by and say hello this morning.
I just wanted to say hello and thank all of the members for your work and dedication. This is actually a working board, and so we appreciate all of the hours and time that you spend helping us make good decisions for the council. I wanted to show our appreciation and gratitude for all that you do.
Great.
Thank you.
All right, we're pleased to have two new council members joining us today, Dr. Feno and Dr. Kivala. I'd like to ask each of you to briefly introduce yourselves.
So a pleasure to meet everybody. My name is Leif Feno. I grew up in Alaska and I did my undergraduate degree in neurobiology at Harvard University, and I completed a medical degree and PhD in neuroscience at Stanford, which is also where I completed psychiatry residency, board certified in psychiatry and addiction medicine. I also chair the American Psychiatric Association's Council on Addiction Psychiatry, which drives policy decisions for 40,000 psychiatrists in the United States. Run a basic research lab just past Schultz down the road, where we work to understand how to more effectively treat addiction. Clinically, I'm affiliated with UTHA. I work through integral care. I run an opioid use disorder clinic, a safety net mental health clinic, which is a training site for psychiatry and family medicine residents. And my perspectives on opioid addiction is that it's a terrible medical disease. The most tragic component of our current iteration is that we know better. We have hundreds of years of experience and knowledge around opioid addiction, cuts across geography, education, gender, ethnicity, race, wealth, and age. So I'm excited to work with all of you to be a resource to help move the council's important work forward, and then also effectively disperse these funds to increase Texas's capacity to treat opioid addiction and access for our patients to that treatment. Thank you. Nice to meet you.
Leif. My name is Paul Kivala. I'm an emergency physician. I did my training in Illinois and Los Angeles County, and also did an administrative fellowship in San Francisco. I've worked around the country from Chicago to San Francisco to LA to Texas to Alabama. And being on the emergency physician side, I'm on the front lines of this issue. And I'm also incidentally married to an addiction psychiatrist as well. So I've seen it a lot of sides. We've had a lot of discussions on this over the year, but I was the president of the American College of Emergency Physicians and represent the 38,000. I've had my ex-waiver way before we actually, as emergency physicians, worked to remove it just so that we could improve the access of a lot of these medications because we are the ones that see these patients on the front line. And so I'm here to share my expertise, and this has been a passion of mine. I agree with Dr. Fango. Psychiatry, I think, is the mind is the control center, and it is a medical disease, and we have to do everything we can to do it. I've seen great efforts, all well intended, and I'm here to hopefully shed a little bit of light on what we see from the emergency side and how I think we should best treat this societal problem. Thank you.
All right, thank you. Welcome again. I do want to recognize Dr. Terry Moore joined us as president, so thank you for joining.
Hello.
All right, I also want to point out that our contracts attorney, Trace Tinkersley, who usually is here in person, is joining us on WebEx and may jump in if necessary. Okay, take care of the minutes now. We'll move on to agenda item 2. You will now consider adoption of the minutes of the September 8th, 2025 council meeting. Members, you have received a copy of the minutes before today's meeting that are now being displayed on the screen now and on page 8 of your council book. Do I have a motion to approve the minutes of the September 8th, 2025 council meeting?
Motion to approve.
Either way.
Okay.
Middle sense.
I have a motion by Ms. Yoder and a second by Dr. Mills. Members, please unmute yourselves, and we will do this by a voice vote. All those in favor say aye.
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 All those opposed say no. Those abstaining? All right, there being 11 aye votes, 0 no votes, and 0 members abstaining, the motion passes. Thank you, members. I'm going to ask Katie to open the discussion on the next agenda item, awarding the recovery counseling expansion grant.
Good morning. In accordance with the council's 2025 grant issuance plan, the NOFA published in August allocated $25 million to the council's targeted strategy of expanding recovery housing resources in the state. 7 applications were received in October. The applications varied in requested amounts and the geographic areas of the state that would be covered. Those applications were all made available to the council on November 3rd in the grant management system. Meanwhile, the peer review evaluation was managed and completed by our partners at Texas State University, Dr. Jennifer Speed and her team. They found 5 subject matter experts to review all 7 core applications. The week of Thanksgiving, those detailed portions were finalized, and we also made those available to you in the grant management system. On page 16 of your board book, you'll see the evaluation criteria, a table listing the average scores, and a 3-page memo provided by Texas State describing the evaluation process and summarizing the panel's takeaways from the 4 top scoring applications. Before I get to identifying recusals or discussing merits of the applications, does anyone care to comment or question anything about the process or how we just chose this, or how the council chose this targeted strategy?
I just have one question. Being from the emergency side, we see a lot of these houses are great resources, by the way. But we also see sometimes they're not supervised always that well. And we see a lot of their clients come back. What are the safeguards that I don't necessarily see that in here, that these are going to be evaluated to make sure that they're doing it, in real time? It'd be great to see, we're going to see that at the end, but it would be nice to see something interpreted along the way as we go forward. I'm not sure it probably was discussed, but I just wanted to see if I can get a little better clarification of that.
Before I jump in, anyone from the council want to say anything? Dr. Mills?
Well, I think I have a couple comments about the top-rated applicant. And I think under the negotiation process that would occur if this grant is selected, before we would fund their proposal, I suggest that we mandate that they tighten up their evaluation criteria and possibly run that by the metrics subcommittee. And we should also demand that they come up with a better plan for addressing opioid use disorder in rural areas. And if they can address those two issues, I'm okay with it. If they can't, I'm probably leaning towards not funding their grant.
Let me go back to Dr. Keeble's question. When we wrote the NOFA, we were very careful to make it clear that these had to be certified homes per NAR. NAR is the National Association of Recovery Housing, and they have very careful standards and different levels of certification.
Again, I'm walking, this is Dr. Keeble, I'm walking into this kind of midway through and I'm getting abbreviated notes, so thank you for that answer.
Sure.
Yeah, we had a long discussion of that, so we had to bring it.
Are there any other process questions or anyone from the council want to talk about how we got to choosing recovery housing as a targeted subject matter?
I was just wondering with like the applicants that we got, I mean, we continue to see the universities and these already state owned, if you will, taxpayer funded entities and at the top of the list. Are we having trouble getting more of the independent and more of the smaller businesses involved? And is there a problem with our process that we're not being able to get more of those folks involved?
I don't want to speak for the council. Go ahead.
I imagine it's difficult when we've got, I mean, I completely agree with you. I imagine it's difficult when we're talking about one potential grant or it's statewide, and I don't know if there's a whole lot of organizations out there that could do something like this statewide that has experience and things like that. I imagine that's why, that's what we're seeing. But I mean, I hear you on that because I was thinking that too.
It just seems like we always continue to, I mean, it's University of Texas here, or Texas A&M here, or University of North Texas. It just seems like that just dominates our grant proposals. And of course, they have people who are very smart people who that's what their job is, to write the grants and do all these things to get it. I'm just wondering if there's any way, if we're missing opportunities with some other organizations, and not that I think that's fine with what we have to choose from today. I worry that like, it seems like a pervasive kind of thing we're seeing. Maybe there's a way for us to ensure that people are knowing about them. If it's a knowledge base, if there's a problem that we're not making sure we've got opportunities for some, because I think it impacts some of our smaller outlying regions a little bit more as well. I know this is statewide, but just, it does probably impact the participation from certain areas too, so.
Dr. Mills?
Yeah, well, anytime you do a statewide grant, you certainly tip the scale towards UT or A&M, something that's got a statewide footprint. I agree with your comments, but the only way to address that is when you put out a grant, put it out as regional grants, which require a lot more staff work. If you're dealing with 20, healthcare regions. But just the way the grant was written as a statewide grant, it's gonna give an advantage to entities, which usually are large universities that have a statewide footprint.
Dr. Louise?
Yeah, thank you, my colleagues, for your comments. I mean, we all know Texas is a very big state, so we're going to run into this problem if we give any grant that has to cover the whole state. It's just going to be impossible for any particular organization to do a thorough job and reach all the rural areas. So we have to be realistic about, people that can do this if we want to give any grant at all. But just in reflection of why we pick recovery housing, we had discussed this a number of times in our subcommittees. Those of us on the field here know that recovery housing seems to be something that a lot of patients are suffering from. It's so critical for them for that to be successful. A number of people have been innovative here in East Texas, have been innovative. And I've seen the dramatic impact of just providing some form of recovery housing, the impact it's had on recovery and continued progress in this field. So that's why we picked this. But the point is that I think we're going to grapple with the issue of who is going to cover the entire state. So I think we, again, have to be realistic and encourage, prospective grant applicants to do the much they can do and direct them. But if we're looking for anybody that will do that perfectly, I think we're probably asking for the impossible. Thank you.
Dr. Fernandez?
Yeah, no, I want to chime in and kind of echo what Dr. Louise said as far as the overall kind of importance for recovery housing in the community. I think a lot of us who do kind of the first line work kind of acknowledge it's a big deficit across the state for folks in recovery. And oftentimes one of the things that jeopardizes the recovery more so than access to Medicaid assisted treatment or other resources. With that said, I think we all struggle and with the thought of, do we approach this as looking for one large organization to then administer the funds for this across the state versus setting up a lot of individual grants? And I don't know if there's a right option. I will say I do think it's a very particularly important topic. So as we review these applications, it could be something that, I would like the council to consider that it might be something that we reconsider for another cycle, or also add as another cycle as a consideration of even doing smaller grants for some of those smaller organizations that don't have the ability, like the UT system, to put out a large proposal because they don't have that infrastructure, but might have the ability in a smaller community or rural part of Texas to kind of tackle or bring housing in those smaller areas. So again, I don't know if there's ever going to be the perfect answer for this, but I think reviewing, I was very excited to see kind of the organizations that did bring forward proposals for consideration.
Dr. Thornton?
Yeah, I just wanted to add in for the new members and for, I guess, the public who may be listening. We considered a lot of these options, and one of the big things I want to echo my colleagues is that we realize that housing is critical, but we wanted to make sure that we could provide, I think, the most palatable version at first before we go into the more regional individual homes or individual small clusters of homes within regions. And so the decision was made by the subcommittees to essentially go with the statewide model, hoping that everyone could propose as many of the regions as they possibly could reasonably address. And I think that's what we end up having here. And I think I just wanted to be clear for the new folks, but also for the folks on, like, these things have been very carefully considered in the subcommittees. And so the subcommittees actually do quite a bit of discussing and work and trying to really arrive at hopefully the best, or at least the best available answer that we have.
No one else has anything, we'll move on to, oh, do you want to recognize Dr.?
Yeah, I do want to recognize Dr. Guevara joining us. So welcome and show
Thank you. Sorry for the technical issues on my end. Good to be here.
It's gonna be great to have you here. Dr. Wilkes, are you here too?
I'm still trying to get a camera.
Okay, all right, we'll come back to you, thank you. All right, moving back to recovery housing. Is there anyone on the council who wishes to disclose a professional or financial interest with any of the applicants or their known subcontractors or subgrantees? I see a recusal from, say your name,
Kathy Gutter.
okay,
Tony Thorne.
okay.
Leif Fenno.
Okay,
All people.
noted, thank you. Are you also recusing yourself? Okay. Anyone online, Dr. Fernandez?
Yep.
Anyone else online?
I too, Robert Guevara.
Dr. Guevara, okay. Okay, thank you to each of you. As a reminder, you may not participate in the discussion or decision regarding the grant awards due to your conflict of interest. Thank you for disclosing those. A few more reminders for those of you who can participate. You should make an award based on the criteria and requirements that were published in the NOFA. The work of the peer evaluators, including the scores, rankings, and other information they submitted, they're for your consideration and recommendation and only advisory. Ultimate award decisions are up to your sole discretion. And then after y'all discuss and deliberate, we'll take a motion to award the grant to a single awardee. You could also include an alternate awardee if you choose. And then that motion also needs to deny the remainder of the applications. Okay, would anyone like to open the discussion?
I'll be happy to open the discussion. Based on the information we provided, I think University of Texas in Houston will be awarded the grant for the recovery housing.
Dr. Mills?
I'm okay with the way the grant applications were evaluated. But as I said before, I think during the negotiations, if University of Texas Health Science Center at Houston is selected, that during the negotiations, they need to strengthen their plan for rural, greater rural impact. And they need to, we need to kind of put their feet to the fire for evaluation scheme that's objective.
What else? Dr. DeMore, Dr. Feldman, Detective Enriquez?
I think I do too. I reviewed a lot of the reviewers' comments and information. I think they were pretty consistent throughout. Scores. A lot of information there to kind of take in. I agree that with Dr. Ellen saying that they open this form decision, right?
I want to recognize Dr. Wilkes has joined us. Partners present, welcome. That brings a total of 13 council members present today. Thank you. Thank you again. All right, members, after discussion just had, do I have a motion to award the recovery housing expansion grant to the University of Texas Health Science Center at Houston?
This is Dr. Mills. I'd like to make a motion to award the grant to the University of Texas Health Science Center at Houston. I would also like to say that the West Texas Centers for MHMR be the alternate. If for some reason negotiations aren't successful, and I would reject the other applications.
All right, members, you heard the motion. Is there a second?
Sorry.
I don't know, we're allowed to get clarification why you want to the second and third ranked applicants, why?
Well, having worked out in West Texas, I can say that I think that proposal is the one proposal that had some focus on rural Texas. So that would be why I would.
Members, I want to back in a second, and we'll do a vote on the first award. So is there a motion? So Dr. Mills, you have a motion to award the Recovery Housing Expansion Grant to the University of Texas Health Science Center at Houston. Is there a second to that motion?
I'll second the motion.
Yeah.
All right, I have a second from Mr. Enriquez. All right, members, we'll go back to the discussion and vote. Do you want to have a discussion? The alternate?
We should vote on let's vote on the award.
Okay.
And then we'll have a discussion on the back end. Okay. Let's do the vote on the award first.
Okay.
The voice vote, so. No, we just did a motion in a second.
Oh, okay. Okay. Oh, sorry. All right. So members, at this time, please turn on your cameras and unmute yourselves for a voice vote. This is the vote on the award to UT Health Science Center at Houston. All those in favor say aye.
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 All those opposed say no. All those abstaining.
Yes, 6%.
There being 5 ayes, 0 noes, and 6 members abstaining, the motion passes.
Now, is there a motion?
Okay.
Do you want to discuss the alternate?
Now, we'll go back to the alternate discussion. Is there further discussion, or is there a motion to name an alternate?
Based on the report of the reviewers, UT Austin seems to be the other candidate to consider here. I can see the third and the fourth, but with respect to my dear colleague here, Dr. Mills, the West Texas Center was actually only for men only as well. Those role-focused program targets men only. That doesn't look, women are much affected in these diseases, if not more, these days than as much as men. So, that's a big disadvantage for such a project to be targeting only men. I don't think we will want that to happen.
Dr. Mills?
Well, I agree. I think that is probably a big flaw in their proposal, but I think that's something, I don't think we'll ever get to the alternate. It's just a matter of reality, but it's possible. Remotely possible. But if I were negotiating with them, I'd say that has to be addressed during the negotiations, to make it all encompassing proposal.
If that is possible, I'm happy to support that. If it's possible that they'll be able to certainly address women. I won't be part of a council that will approve a statewide grant only for men.
So I think we're looking for a second on Dr. Louise's motion or a different motion.
Let's be a second on the motion for the University of Texas as the alternate.
Okay, so members, we have a motion to make the University of Texas at Austin an alternate board. We have a second. So members, at this time, please turn on your cameras and mute yourselves for a voice vote. All those in favor say aye.
Aye.
All those opposed say no.
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 All those abstaining. Those abstaining.
So just to be sure, Milton, Wilkes, Enriquez, and Eloise were ayes.
There being 4 ayes, 2 noes, and 6 members abstaining, motion passes. And members, going back to the first vote that we had on the recovery housing grant to the UT Health Science Center in Houston, there were 6 ayes instead of 5. So 6 ayes, 0 noes, 0 members abstaining.
6 ayes, 0 noes, 6 abstentions. Okay, staff, thank you. Staff will proceed with negotiating written agreements with the University of Texas Health Science Center in Houston. Okay, ready to move on to the grant issuance plan? Rules require the council to adopt an annual grant issuance plan. On page 22 of your books, you'll see the proposed plan for 2026. This was drafted by staff in consultation with the Futures Working Group, also taking into consideration survey input from members and stakeholders. As currently drafted, the spring opportunity would be a single statewide grant for criminal justice. The summer opportunity would be a short-term regional core grants for pregnant and postpartum women. And the fall would be a longer-term regional core grant to expand medication for opioid use disorder treatment. Would anyone from the Futures Working Group like to add anything? Start with Detective Enriquez about the first project proposed.
Yes, first project, opioid abatement within the criminal justice system. Lucky to be in this group. We had several discussions ongoing, a lot of back and forth. This is something that's close to heart for me personally. I think that a large percentage of the prison population suffer from OUD. Then one of the natural progressions of addiction, unfortunately, does lead to incarceration. So I think all that being considered and the programs that are in place and enhancing these programs that are in place will give us, the best opportunity for ideal attention. It was difficult having that conversation without you, Dr. Mill. I know that that's close to you as well. And that's why I wanted to kind of get this on the agenda so that we could kind of open up discussion, get your opinions as well as everyone else in the course.
Well, I certainly have opinions about it. for those council members who aren't familiar with my background, I spent 25 years working inside the fence, taking care of incarcerated patients. So the state prison system is controlled by two entities as far as healthcare. Southeast portions UTMB, northwest portions Texas Tech. Vice President for UTMB for Correctional Managed Care is Owen Murray. Vice President for Correctional Managed Care out west is Cindy Jumper, I believe. The other element we're dealing with here is the county jails, which is a massive problem. Houston, I think, what, there maybe 10,000 residents or more. Fort Worth's right now at 4,000. So there's like 5 really big jails. And for the most part, jails house people that are awaiting trial. Maybe half the people who are arrested are released within 3 or 4 days through the PR bonds or putting up a small financial bond. So what you're talking about here is a case management issue. And you're talking about an interface with the judicial system. You know, if you're trying to get somebody in Fort Worth County Jail, you know, Tarrant County Jail, hooked up with a treatment program in the city, and the judge cuts them loose Friday night at 8 o'clock, they're not going to get hooked up. So, you know, the judiciary has a lot of impact about release dates and times, particularly at the county level. And of course, all the county sheriffs are elected officials, as is the judiciary and the criminal courts. And so if you're going to make an impact on the county system, you have to get the buy-in from the sheriffs at the big facilities. You know, you're going to have a difficult time with someplace like Limestone County, maybe have 40 prisoners, you know, and really no full-time medical staff other than a couple LVNs. The state prisons, you know, we've got to get the buy-in from TDCJ. These grants would be focused in on private organizations because the state TDCJ's budget is controlled by the legislature, you know. And so we would have to get the buy-in to put these case managers have access into these facilities. We'd probably have to get a buy-in to aggregate individuals who need opioid use disorder treatment in certain facilities, and so that they can get counseling, they can get hooked up with outside resources like housing, like, you know, drug, you know, medication for opioid use disorder. And, you know, I'm just, I guess what I'm trying to point out is the complexity of the situation, you know, and so we would have to meet with the big, you know, sheriffs of the big jails. We'd have to meet with the people who control, you know, the medical treatment of the state prisoners, get their buy-in, because without their buy-in, you can put out all the money you want and it won't go anywhere. You know, it'll just be a dead end. So, apologize for taking so much time.
Dr. Keeble?
Dr. Keeble, from the emergency department side, I think I'd like to echo Dr. Mill's discussion on the complexity. There's both the prison and there's the jail system. Jail system gets released very quickly. And oftentimes they're released with minimal Suboxone, and they immediately go straight from the jail to the emergency department. Actually, a lot of times they're discharged early from the jail because they're in withdrawal and they're sent to the emergency department. So you're looking at 2 different things. The second thing is that in the jail population, and I've been outside the jail population in the EDs. And one of the things that we get is a tremendous number of overdoses from the prison system. And I just to let everybody know, and this may be common knowledge, Suboxone, the street value is about $5 for a film. The jail, the value in prison across the country is $150. This is one of the most trafficked medications in the jail system, as is K2. And so, I mean, I can provide that information to people, but I think we have to really delineate what medicines we're talking about, how we're going to do it, and if we're going to be discharging these people from the jail, they don't need just 8 milligrams of Suboxone. They're going to need like 48, like the California Bridge program. So it keeps these people a 72-hour gap so they can actually get help rather than be discharged and go straight to the emergency department to just create a new system here of problems.
If I could add to that. To echo what's been said already by Dr. Keebler, the risk of fatal overdose directly after discharge from carceral systems is incredible. 40 to 100 times higher risk of fatal overdose, a short window of time. We had a discussion around some of these complex system level complexities and also around some of the pharmacodynamic complexities of buprenorphine. And one thing I would like to bring up for consideration by the council is the potential for the use of long-acting injectables at the time of discharge from the carceral system. These are essentially 28-day single shot versions of buprenorphine. They have a REMS around them, so they can't be easily trafficked because the distribution is highly controlled. I don't know, I don't have jail experience from the medical side, the treatment side of things, but I'd be curious to hear from folks who do, if that would be something that would be more attractive to the people who hold the keys here.
It's expensive.
It is expensive. So it's about $2,000 a dose is the cash price for a single injection. That's true.
So I think, and again, I appreciate the comments of everybody so far. The question I had with this was more of a logistics in addition, because, you know, being in Houston, we've worked with Harris Health and Harris County Jail on some of the, you know, opportunities that are available to do some of the things we're talking about. I think from our perspective as the council, if we're gonna have a grant opportunity, like Dr. Mills says, then we need to make it approachable by the entities that actually do something. And so is TDCJ an eligible applicant? Are there sub-entities? That's what kind of big question one. The question two is, how do we make this approachable by the counties, if it even is? And then kind of the elephant in the room is the municipalities and the counties have received funding. Are there ways for us to, not necessarily, we of course can't tell anybody what to do, but just provide kind of like the NIH version of like a notice of special interest. Hey, let's focus on this. Here's an opportunity for some of those county funds to go directly into what we've somehow, you know, deemed to be a high need, high priority event. You have the money already, and we're continuing to fund that. That's already with the entities. They don't have to write applications for it. And so I know I'm kind of mixing two batches of money, but I really think the logistics of having the money go to the entities that you all are all talking about and have experience with is what's going to be the tricky part about putting out an application, like, or a call for applications like this. Because like what Dr. Moore brought up early, we don't want just one entity that maybe can cover a small region of the state. How can we actually push to get this done from, you know, El Paso to Beaumont?
Dr. Keebler again, I really think you're right on track, and as are you. I would much rather like to see 3 or 4 demonstration projects of studying long-acting versus high-dose Suboxone and see what happens to those people in 30 days. You know, let's see, we do this in 2 or 3 rural areas, 2 or 3 urban areas, and then make a decision where we're gonna put all these resources. We don't know the best solution, and the best solution we got experts here in the room, we got experts across the country, and no one's done these head-to-head things. Let's use our money wisely. Let's get some more information. Let's figure out how to do this. That's how I would like to see this grant go.
So, and the lawyers can back me up on this one, but in terms of the question related to, can we force the counties to do something? We cannot, between the settlement agreement and the state law. So we don't have any oversight of their funding. Now, the legislature could technically say to the counties, we want to have some kind of, with a bill saying, hey, we want you to provide certain things to the comptroller and whomever else. But right now, we don't have any control over that. So I think it does kind of limit us in that piece. I think a lot of what y'all are saying makes sense. I mean, one of the things that I wanted to explore as we move forward is not doing 3 grant cycles, but to do 2. That way we can kind of focus in on a little more. And I know that our staff here are amazing, and we've got a lot of grants, and there's a lot of work to be done on our current grant cycle. So, if we want to have a continued discussion, but one of the things I was going to propose as an amendment was to do 2 grant cycles rather than 3. And that may fit better in terms of reorganizing the criminal justice one, which I think is incredibly important, to something that you recommend, as well as maybe doing that long-term one, that the last one, and taking out like postpartum short-term. Just a thought.
Dr. Fernandez.
I think Dr. Mills was hands up before I.
Go ahead.
Yeah, this is Dr. Mills. I think it would be a big mistake just to put this money out as a statewide grant. Because the big problem with corrections is a complete lack of evidence-based practice research, because they're so abhorrent about doing research like in the federal and state prisons, for historical reasons. And so I think what would be best to do is do some pilot projects. I agree with that. I think, if we can find one of the big 5 jails in the state where the sheriff's on board and the judiciary in that district is on board, or, so, it's not just up to the sheriff when you get released, it's up to the judge. And if we could get one pilot project at one of the big 5 jails in the state, and then find a rural area that can't be too rural, because you have to have an adequate number of people, but someplace that's not one of the big urban areas, and do some pilot projects comparing, the long acting, which is expensive. I mean, I'll grant you that, but versus giving them a blister pack with a number of pills in it, and see which works best, And once we know what works best, we know what to fund. And I don't think you'll be able to put a statewide grant out on this, because there's just so much difference between Dallas and Fort Worth and San Antonio. You're going to have to put out some kind of focused regional grants. I'm not saying 20, but once we figure out what works, then we need to put our funding there.
I like the discussion of looking at how we can kind of improve kind of outcomes for the correctional health system. I think in Dallas we have a kind of very large system, and there's a lot of opportunities of how we can help folks in recovery being released from correctional health. With that said, I also like the discussion of potentially looking at kind of research initiatives of how we can improve outcomes. But I see those things as kind of separate arms. I do think there is a lot of low-hanging fruit in this space that I would like us to consider as a kind of cycle, kind of dedicated to kind of the justice system that we could push out or consider at regional levels. Because again, some of these things is just, some of the areas might just need funding for coordination, care. That's a big gap of area. Like folks are released into kind of the ether without any kind of transition or warm handoff or organizations that can receive them and understand their special needs. I think again, those are just very simple, low-hanging fruit that we could consider. At the same time, maybe we could dedicate a cycle because I think there's still a lot of avenue to look into improving the literature and the research on treatment modalities and addiction, especially looking at, correctional health is an area, but there's still a lot of opportunities for kind of research in this space, especially in Texas. So I wonder if we want to just kind of have it as kind of separate considerations. One cycle looking at regional grants for correctional health and the justice system, and then maybe thinking of another grant that we actually we need to kind of consider and workshop this a little bit, but either multiple smaller grants looking at awarding different organizations looking at meaningful research projects that could better address the needs in Texas.
I might come back to you, Dr. Fernandez, for a motion. Dr. Gordon.
Dr. Louise, I think has hand up first. You go ahead.
Yeah, thank you, dear colleagues. Dr. Mills, I think Dr. Mills gave us a very important information. Apparently from what you're saying, just two medical organizations take care of the jail here. You mentioned UTMB and is it Texas Tech or the other one? I just wonder, obviously, it's apparent that except for Dr. Mills, a lot of us are not too familiar with the intricacies of what happens in the jail. I deal with them here in Tyler, but certainly not enough to know what is happening there. Should we really chat with these stakeholders to really know how we can help them? I just have a feeling that we're making decisions on an area that we don't fully really understand. I probably don't even understand the kind of help they need. Will be an opportunity for us to chat with them and really know what they need, how we can help. I agree with the studies that we talked about, but those are long-term issues. If we're going to do a study, before we know the outcome, it will take us another 3-5 years to know the outcome from that study. But in the interim, should we chat and find out how we can really help at low-hanging fruits like Fernandez is talking about coordination and areas like that, particularly with these two organizations that cover most of the state.
Yeah, this is Doug. So for the Harris County area, we've done some of that. We held listening sessions, we had stakeholder engagement forum, and it culminated in a conference we hosted back in August, specifically addressing OUD treatment before, during, and after in the jail setting. So I think some of that I think there's a big need for that, because just in Harris County, there's a lot of different perspectives on what could be done. Again, I think this goes back to, do you have buy-in from the people who can make the decisions? And are they going to be, how do they engage with the funding that we're proposing? Because we kind of have two paths. One, we can make recommendations as a body and say counties should do X, Y, Z, and it's going to have maybe a touch of impact, but not much. Or we can incentivize them to do what we've all talked about by saying, we'll work with you, but that will need us to really lean into the targeted aspect. We talked about this years ago, back when we first voted on what allocation could be truly targeted. And one of the largest, correct me if I'm wrong, but my understanding of the target initiatives can literally be us saying, we need this type of work to be done. And then we go to the vendors, or in this case, the counties, and say, these are the projects we need done in these areas, yes or no. And if I think what we're getting at is not a statewide call, which is what is proposed. I think what we need to get to is a very targeted strategy where we say, hey, we do have money. This is what we want to do. Maybe we have listening sessions and can meet them in the middle, some if there's sticking points. But I know that there are counties that share, like I said, we met with county officials, city officials, stakeholders, the people doing the work on the ground, street outreach. There's going to be a lot of different perspectives. I can't only imagine if you go to multiple counties, but we need to make the money approachable and very clear what we want out of the situation, which is either to prevent reincarceration, make sure, linkages to care are happening immediately after discharge. Whatever those outcomes are, I think we communicate that, we make it targeted, and we open it up. And who engages with us, great. It's going to be a very tight, targeted strategy, though, not statewide. Sorry.
Is that a motion?
It's not a motion. That's way too much to move. But I'm happy to do that if after John talks, I will accept us.
Okay. Dr. Mills?
Well, I agree with what Doug said. You really have to get, if you're talking about one of the big jails, you got to get the sheriff's buy-in. You say, what's going to work for you? Because the sheriff, he or she is an elected official. And if they're not buying what you're selling, that's not going to work. And the same way is true for TDCJ healthcare. You have to find, what works for Owen Murray and what works for Cindy Jumper. Something you have to propose a plan that they're going to embrace, because without these stakeholders' cooperation, you're just doomed to failure. And one other point I'll always make, when I was training people in the jail, I said you have to be very careful about providing treatment programs in the jail, because treatment programs are not readily available outside the jail. And so if you have great programs in the jail and no programs outside the jail, people will be knocking off a 7-Eleven to get drug treatment. So you have to kind of look at this as parallel. You don't want to incentivize people to come to jail just to get decent treatment.
Dr. Fernandez?
So I think Dr. Milton's hand was up first.
Oh, please.
Yes, Dr. Mills just kind of took the the words out of my mouth there. My background's in infectious diseases, and there's been debates over the years about how you best impact, let's say, the burden of hepatitis C in this country, and it's very fertile ground in the prison system to find people that are infected with hepatitis C. But you have to be careful about how that's perceived, because just like treatment for opiates, the treatment for hepatitis C is incredibly expensive, and you may be incentivizing people to commit a crime in order to get their treatment. So I just think that's something that needs to be thought about.
Fernandez?
Okay. Yeah, I'm very supportive of Dr. Thornton's kind of earlier comment. I do think to have very clear expectations if we're going to be kind of targeting initiatives around kind of correctional health. There's a lot of players, and Dr. Elu, multiple folks have actually brought this up. There is a lot of various players in this field. And I'm sure if you look at the different regions will probably have different pressures regarding what they're experiencing. I just don't want to delay distributing the money to these very needed locations. So I like if we're going to be dedicating kind of a cycle to correctional health and the justice system, or those who are in that space working on improving the outcomes, and we can really work to kind of improve that. But looking at a kind of region, and then like we did at kind of 2 cycles ago when we're looking at the smaller grants, we let the regions show what are the organizations in these spaces that are looking for funding, and we do the same thing as we did before, kind of distribute the smaller grants according to the regions and the response. But with the caveat that I still like the idea of there's a lot of potential research that could be done of how to improve the outcomes in Texas. And I still like the idea of having kind of maybe a cycle more broad later, that we kind of open it up to folks looking for grant funding that could help maybe answer some of these questions. And we don't necessarily maybe even, that again, that would need to have a lot of thought. I would love Dr. Thornton's thoughts on it. He has a lot of experience around this, but I do think there is a lot of potential also if we think about kind of the outcomes or the specific areas we would like folks to investigate. But I still see them as kind of separate categories, and would love us to kind of consider both.
Before we go to motions, I should have clarified a few things before I open this up. There are 5 members on the Futures Working Group. Ronnie, Dr. Fenno, Catherine Yoder, Dr. Guevara, Dr. Demore. They all participated in this conversation. And then another just important reminder, the way your rules are currently structured, your grant issuance plans have to be 25% targeted and 75% regional. And the regional is when you meet those very careful percentages to the 20 regional healthcare partnership agents. Before we get into motions, sorry, Dr. Fennis, go ahead. Yeah.
Yeah, I love this discussion. I just want to emphasize, regardless of whether we venture at some point into sponsoring research, I do think it's critical that our criteria for grantees includes discrete, useful, measurable outcomes that we can use to inform our future work. So I just wanted to make sure that was clear and said.
Yeah, this Doug. I'll echo that, and I was gonna bring it up. I don't, based on the historical conversations we've had, I don't think we're gonna sponsor true research. But if we go the targeted route, we can go and be very deliberate with what we expect them to measure. And then maybe the council is the one doing the data analysis procedure or whatever that may be, but the big R word. But anyway, may I make a motion?
How about if we hear from the Futures Group briefly about the rest of the plan? And then we could do
all together.
Or, yeah, but I don't want to forget the rest before we move these. Anyone from the Futures Group want to talk about the pregnant postpartum project, or
I will say, I think, and this kind of goes to both questions, so I think, correct me if I'm wrong, as the motions, we could do targeted, and that could be multiple grants, and they say spring, the regional one, and that could satisfy the 25 and 75 and have no issues. Correct, we're gonna do multiple for the spring 2026.
This is supposed to
Sorry, I meant fall. Yeah, so, I mean, I think, one of the things that I like to look at was the postpartum because of, kind of the outcomes for women in Texas. But that could, individual regions that want to apply for that can apply for it under this, the fall. And I think the criminal justice one is, like many have said, is ripe for needs and funding and things like that. So I'm as a futures work group member, I'm very comfortable with the fact that we kind of switch it up and potentially only do 2, and that's the issue that I would recommend.
Yeah, this is Doug. the biggest gap for me, and you all did great work, these are all critical topics, but we have 1-year grants that are currently approved and then they're being funded as we speak. What I really don't want us to do is approve a 26 plan without having an opportunity for at least the most successful of those 100 or so grant applications to be renewed. And so even if that means combining, because the topics, the grant application cycle doesn't have to be defined by the topic per se. We can have, my understanding is it's the category that defines the grant application topic. And so as long as the topics that we have fit into one or more categories, and we can combine them, have those as being cores, and then we're just kind of letting the communities know, these are the key areas that we want you to focus on. But if maybe there's an opportunity to combine those and then open it up a separate core where they are either renewals or some type of way for the 1-year projects to continue the work they're doing. Because on the numbers subcommittee, what we want to do is be able to say, oh, out of this 100, even if we have 50%, 40% hit rate, that's still 40 or 50 groups around the state that are going to have done a good job that we want to try to incentivize to continue working. Because I know, having done it myself, but also working with the community groups all throughout the state, one of the hardest things is the constant start, stop, hire, release, or beg to work, volunteer nature of having these like funding opportunities that kind of are not as continuous as could be. So sorry, I brought it up earlier, but I thought we were gonna do them one at a time. I think the biggest thing we have to really at least have a conversation on is having a pathway for grant renewals of the people that we're funding.
Let's support that. Dr. Mills.
This is Dr. Mills. Yeah, I really agree with what Doug said. You know, if we have some successful short-term grants, why are we going to pull the rug out from underneath them? You know, now if we give them a grant and nothing really happens, they don't have any evidence that they've done anything, fine, they can go away. I was going to comment on the pregnant and postpartum women community-based opioid recovery. In there, they mentioned training obstetrical residents and other healthcare providers. This is a 1-year grant. I mean, I sit on the ACGME milestone committee for one of the specialties, and I can tell you, nothing's going to happen in postgraduate training in a year. And you have to incentivize the trainers, you know, be that UTMB or whoever, to modify their obstetrical residency programs, you know, or, you know, nurse midwife program, you know, and you have to change their curriculum, and that's not going to happen in a year. So my comment about the 1-year time awards that affects, you know, the subset of training in there is that, you know, you better make it at least have an opportunity to at least have a 3-year grant or something so you can actually modify their training programs.
Yes, Dr. Beagle.
Yeah, I'm sorry, I missed part of this discussion, but I think sustainability of all these programs has got to be important. And whether it's community paramedicine, the projects all show great value, but there was no sustainability. The funding wore out and the programs went away. So I think at some point in time, we need to sit there and figure out, otherwise we're potentially perpetuating the problem. One of the things that also we're talking about opiates right now is MAT. We used to get Narcan packs for $4. That was our cost from the ED before this stuff. Now that we are giving these packets out, the cost of Narcan to EMS agencies is now $25, $30, $45, because now we're funding it and everybody knows we're funding it. So we need to sit there and say, if we're going to be doing this, we're going to be negotiating with the power of the state of Texas to make these programs work, so they're sustainable down the road and they don't just become incredibly expensive and all of a sudden the funding's pulled, or we give the same funding, but now we need 3 times or 4 times, or as Narcan saying, 6 times to 10 times as much as we did, 10 years ago. So I think these are big problems that we're looking at. And we need to really think about this in a large scale.
Did anyone from the Futures Group want to describe the fall project?
Yeah. Happy to. So the fall project is for expanding access and capacity for community-based opioid treatment. It's a multi-year project. It's listed as 1 to 3, but consistent with our discussion a moment ago, I think it would be more appropriate as a 3 to 5 year award. I don't think you can do a lot. I don't like 1 year grants personally, for a lot of the reasons that were stated. It takes forever to hire people, it takes forever to get the money. By the time you get started, the grant's over. So I would prefer longer grants. The goal is to expand access, and doing that in 2 ways. Well, in a number of ways. Some of the examples that we discussed were substance use navigators. Substance use navigators are they work in a hospital setting, typically, often in the emergency department, but across the floor. They function as a specialized social worker that's familiar with the local resource landscape, proactively interact with patients to directly connect them with community-based treatment. Hospitals like them because they reduce 30-day readmission rates, which helps them to lose less money. Second one that we discussed are EMS-driven approaches. So we have that here in Travis County. It's being launched soon, I think, in Williamson County, Bexar County, and Dallas County. So we've treated thousands of patients over the last 10 years. It's a single ambulance crew that responds to all 911 opioid overdose calls. They start buprenorphine in the field, bridge patients until they're able to get to a clinic. They also can act as a backstop for patients who are stable on buprenorphine and lose their medication, adults in the sun, whatever happens, goes in the wash, which alleviates some of the pressure on emergency departments to have to perform that function. And third is expanding access in rural areas by incentivizing existing providers who may not be treating opioid dependence currently to start treatment. So that would be primary care providers, et cetera. Folks who are already there. There's no way we're going to train enough psychiatrists to do this. And primary care providers already provide the vast majority of mental health care in America. As far as sustainability, this was also a topic of discussion. One of the things that we discussed was covering 100% of the costs for a period of time, and then having that percentage decrease over time until at the end of the funding period, it would be 100% funded by local entities. Maybe I'll pause there for response. Anybody hate it? Love it? Have other ideas?
Dr. Guevara and Dr. Moore, you were also in the Futures Group. Do you have anything you want to add before we start taking amendments?
This is Dr. Guevara. I don't have anything to add. I think all these comments are very helpful, and I wish the Futures Group was bigger. A lot of our decisions on what to fund were informed by some of the surveys that were done, if I'm correct, of the whole council. And if y'all didn't get a survey, y'all didn't get a survey back. So we went with both the survey results, correct me if I'm wrong, Katie, plus some of the discussions on the committee. But it's clear that there's a lot to think about, and a lot of members, panelists have experience in the criminal justice system. I don't, but I do appreciate that, and it's definitely food for thought, and as well as the funding, how long the funding cycle is. So, but we had a very good discussion. I wasn't there for yesterday's meeting, but I was there for the 2 other meetings we had, and it's a difficult subject, but we all know that the funding's there. We want to get it to the areas of Texas that need it sooner rather than later. But a lot of these logistical issues are something that have to be worked through, and I completely agree with choosing an area of funding that is going to be doable and that is realistic. some of these topics are, there's no doubt that it's needed. It's just choosing the right area of focus and how to best get that to them sooner rather than later. Like I said, thank you.
Dr. DeBorn?
Yeah, I think everybody's comments have been good, and I missed yesterday as well. But I think one of the things we talked about early on in the futures group also, and looking at all these, was kind of our scoring criteria. And to go back to my concern earlier about how are we getting like certain entities involved and making sure that people are having a adequate opportunity to apply for these, and it's not being dominated by state organizations. We did talk about the ranking and how many points and how we score these. And I think with the proposed project plan, we had talked about that being a little bit heavier weighted, just to ensure that we're not overly doing it based upon the financial resources, other things of a organization. The fall 2026 plan for the regional strategy, I think, will be a really good opportunity for some of those smaller organizations to get in, and as well as the community-based program for the pregnant and postpartum women, which is definitely a significant need. So, but I think it is a very complex thing, and I do agree with the commentary, by the way, that the 1 year grant is probably suboptimal. We definitely need to make sure, as we're looking at these, to ensure that some of those really good ones that we got approved and that they do a really good job can continue to do a good job, and we don't shut them out for and not be able to extend that grant in future years.
Okay.
I have an omnibus motion,
Okay.
if I may. All right. And again, please don't second it if you don't agree with me. I figured it's easier just to lay it all out there. Okay, I move to keep three funding cycles, but to change the funding from the summer 2026 from 25 million to 50 million. Change the fall 2026 from 50 million to 25 million. As well as changing the summer 2026 timeframe from 1 year to 2 to 3 years. As well as changing the scope of spring 2026 to be a tightly targeted focus on the same topics. And we'll need to engage with the stakeholders, including the key healthcare providers for the state prisons and major county jails, to make that happen. As well as the summer 2026 to change from just having a regional strategy on pregnant and postpartum women to including a broader short-term core awards, which can include renewals. And we can have a preference for new grants if they focus on pregnant and postpartum, but not required.
Yes, I also have a question. So process, go ahead.
Okay, yeah, well, what happens? Do we post changes or vote, clean vote?
I think let's just go.
Yeah, you have to
Let's go with
second
the
it first,
discussion.
and
Well,
then we can discuss.
Okay.
don't second it until you're all.
Don't.
Again, I'm sorry,
Sure.
it's got a
So the big things are, one, can I summarize it without saying the verbiage I want to use exactly?
Sure.
All right, I don't know what I want to do. Someone needs to hit me in the head if I'm never saying that out to. But the idea is, the big change is broadening summer 2026, both in funding from 25 to 50 and time frame from 1 to 2 to 3 years, which that has to eat into one of the other two. I think the third strategy, third default is probably the one. But again, you can argue with that. The other big piece is changing the scope of the currently proposed spring 26 instead of being statewide to be narrowly targeted. And that requires, what do we call it, knowledge?
Subject matter experts.
Subject matter experts. I recommend the people John recommended, the healthcare providers for the state prisons as well as the major county jails. And
Are you changing that funding amount or keeping it the same? Sorry.
keeping it the same.
Okay.
I didn't have a good reason to change it or not. And the only reason I'm reducing 3 is because in theory, people for the fall 26 could apply for the new summer 26. It's just without the voters. But like in theory, if you have the same, because the way it is, the categories are open enough that you could, in theory, apply for an idea you have related to MOUD expansion in the broad summer 26 category. But now we're setting aside 25 million specifically for MOUD expansion instead of mixing it all together as some.
Questions, Dr. Penny?
We have a few.
Is there a second?
Not yet.
Do we need a second before we ask questions or not?
No.
Wait, so no second
Yeah,
yet?
you can discuss.
Yeah,
We can
discuss.
discuss now before saying.
Yes, I think that's probably best.
Okay, you wanna go first?
Sure.
Go.
Well, I would say, well, buprenorphine is one of the most effective medications in all elements. So my priority, I would suggest that priority for our group is to expand access to evidence-based treatment at all costs, which I think is what we're saying the same thing here. Would it make sense at all if we're considering some of the work that could fall under the postpartum pregnant women community-based grants, to move some of that money then to the fall and have a specific call out in the fall for expanding access in the community to pregnant women, in some ways just combining parts of summer 2026 with fall 2026. And I'm not sure, curious what you think, Catherine. It would be worth just combining them full stop. Or if we should segment out some of it for summer and some of it for fall.
Go ahead. Sorry, you're asking a question.
So this is my concern too. Is I'm looking at the summer and the fall. And I see a great overlap, except for the summer is targeted at women. And I think this is a very vulnerable group, so I think there needs to be some type of priority for that. But those programs very much overlap. And yet 2 out of every 3 addicts are male. So I'm not sure we want to necessarily take the money from the program 3, which would potentially include 2, or then give some type of preference for those programs to make sure that those groups are targeted, or it's mandated that there's some policy in place to target the summer group. So maybe it's still the 2 phases, but I don't think I want to necessarily take the money from group 3 to move it to group 2 for that reason, because it's basically an overlap.
Could we just do one core and have kind of the notice of special interest model of, hey, here are 2 big categories we want you to ideally focus on, but then also allow for renewals, and then it's just functionally, it's just one big core, 75 million that happens once.
So that's kind of what I was thinking, more or less, and maybe.
Yeah, we're all thinking the same.
So I think, and Ethan and Katie, I would like to get your opinion on this in terms of y'all's workflow and kind of grant cycle. My thought process, because I think we're saying the same thing, is okay, let's focus on spring and have it multi, not just one. And then maybe the summer let's look to see potential renewals. Let's look at what is going on with our short-term ones and see if some of them are doing good work, have good metrics. We want to renew, but nothing else but that. And then fall be the big one that has the new funding for MOUD with the special emphasis of pregnant postpartum women as one of the special groups or something like that. In terms of how we are in terms of getting out our 2025 last grant, I know there's gonna be a lot of work that are gonna be done now until before January, as well as after January. So I think to me that would give more flexibility in terms of work product, as well as recognizing that some of our short-term grant holders, which should be renewed because of the good work that they're doing.
So you're proposing a spring criminal justice, a fall core combo, and then also like a tiny summer one for renewals.
Correct. The renewals, and it could be, up to, because that was a 25 million, correct?
Yeah.
It can be up to 25 million, but really it is focused on, okay, which ones are actually doing the work and the good work we want to renew. So it may not be 25 million, it may be part of it. And then,
But before I rain on everyone's parade with the lawyer's thoughts, are there other ideas?
Just to make sure I understand, so you still 25, 25, 50, but we're folding the focus on obstetric postpartum care into the fall core.
correct, as one of special,
As
groups,
one of
but you can be,
yeah.
do it other things, yeah.
Let me, I just, the way that we structured the short-term core grants that we are currently executing that you awarded in September, those were never, we never set those up to be possible renewals. Those were finite 1 years. There isn't just a one pager you can fill out to apply for renewal. You have to start over. That's just how it was structured. In the future, we'll keep that in mind for future NOVAs, but if anyone's out there holding their breath, hoping to get awarded a second year, that was, we never made that promise.
And I should probably clarify, I call it renewal, it's probably not the correct word. It's essentially an application to show how your program performed and then reapply. Reapplication.
Because reapply is very different.
Yes.
Got it.
So,
And the only reason I put it in summer 26 was more of a logistics. They're gonna have 6 to 9 months worth of progress. You don't have 12 months progress, because then the money wouldn't come for
right,
another 6 months.
sure.
But, so that's why I try to attach it to the summer, but knowing that we can't just renew. It has to be an application cycle, a core application cycle, that it gets either, it owns it, that time slot itself. But I didn't want to disparage the content that you all came up with at all by trying to say, well, we can have the reapplications broadly. So the whole core has to be broad, but we can kind of guide people by saying some sort of preference will be given. We can even put it in the scoring sheet. If it focuses on the core topic, the main topics we want to focus on, pregnant postpartum, MOUD expansion, whatever that is a D in. And we can give, my understanding is we can vote on the scoring criteria. We can give bonus points, for lack of a better word, to priority areas of the
I think we could figure that out. The lawyers haven't rained on that yet. So so the core, so we're talking the fall core would be 75 million for these two subject areas and other areas where people want to apply, with some emphasis on those two areas. I think it would get a little tricky when it comes to, is everyone only allowed to apply once per region like we did last time? How do we do the scoring? Those are all things we can cross that bridge later, but for the purposes of today, this is an excellent start. Yes.
I mean, this is my concern. My concern with the pregnant women is the rural areas. Is that they're not gonna have critical mass necessarily without including bigger groups. So I think, part of it could be, if we're gonna keep that summer flow, that there's some type of priority to making sure those people get care. Whether it's, in the hospital or in the clinic or something where they're at, it's not a separate lead. You want these people to get care at their OBGYNs with this. So it's almost like a mobile system or in the ED or something like that, because they think that they're going to go to their obstetrician and then go to a separate appointment, the chance is like zero. If anything, they're gonna fall either onto the legal system or they're gonna fall onto the ED system. And neither one of those is where I think we want these people to go.
Does anyone online have any thoughts?
I think we should probably go, like was mentioned, to a 2 cycle per year system. I think these 3 cycles per year is becoming too cumbersome, and we're just running on one cycle is running into the other. I mean, just like you said, we just awarded only about 20 of the 100 their funds by this time. I mean, probably by February, some of them haven't gotten. We just be getting their money, and then we're talking about to evaluate them in summer. I mean, so maybe that's what we should first decide, that maybe we just do 2 cycles per year so that we can think through some of these and give people enough time to do the work, and then we have enough time to review them as well, and do a more thorough job than this apparent rush to me.
Anyone else online? Anyone other thoughts? Might be ready for any motion.
I just wanted to reiterate one thing for the fall, because I would like to change it from the period of performance from 1 to 3 years to 3 to 5 years.
Are we trying to combine summer and fall I'm fine either way. If we want to say, hey, here's the one core we're gonna do, and then we can label it as summer or fall, whatever. $75 million, but then have the performance timeline be the same. Because it's just one at that point.
Say that last part again.
So right now, summer 26 is 1 year.
Yeah.
I propose maybe 2 to 3 years. There's a proposal to change fall 26 to 3 to 5 years, which I think is fine. Would it be okay if if we're gonna combine them anyway, make them all 3 to 5 or 2 to 1? Yeah, 3 to 1.
Yeah, I like that, and I think this also gives the people, if it's almost a similar proposal, if they applied this summer and they didn't do something they need to do, it gives them a time that they might go get some feedback to resubmit. Because I think there's gonna be good ideas here, and we're so new into this process. I know you guys have done such great work, but looking at what are the measurements, I'm thinking about diversion, overdoses, recidivism going back to jail or involving in the prison system, of ED visits, of satisfaction, of sustainability. And I'm on the numbers group, and we don't have good numbers. And I did actually a fair amount of research on this. There's no good numbers.
Thank you.
Okay, there is no good numbers. But we need to really think about this as we continue to just give out money. And the price of Narcan has gone from $1 to up to $1,500 at sometimes for an injector. If we just keep doing that without any outcomes, we're gonna make this problem potentially worse than better, with all the best intentions.
Just to clarify, Dr. Kavilla, and there isn't a motion yet, but I think the talk was combining summer and fall into one. But you just mentioned.
I'm just wondering whether we should do summer and then fall, like a first one for summer, of a smaller amount, and then do it for fall, but give them feedback early for the people that maybe didn't make it or didn't score well, so they can readjust what they've done. Because I think there's a lot of good ideas. I mean, I think we just looked at the last one, the statewide grant. Taking out one little aspect of it really undid some of these studies. So I just think we need to think about that. If we're gonna get broad regional, and someone's got a good idea, they go, oh, we can do that. That we give them an option to adjust and not get knocked out of the cycle.
So correct me if I'm wrong, we have that opportunity right now with our final grant of 2025.
The fall, no, but, right, there's about to be, another, our long-term 1 to 3 year open-ended, non-strategic, 2 of the 4 categories, that's gonna go out soon. So that will be enough. That will be.
Then that's fine.
Okay.
Yes, because I think that'll give the opportunity that you're looking for without having 3 grants this cycle. And I think that's kind of where I'm concerned is that we're having 3 grant cycles and we're still on the last one here. And I hear you in terms of, we don't want just pushing the money out. We want it to be more strategic. And I think it would do it if we could have only 2 grant cycles this next
Fair
time.
enough.
Is there any utility in moving the renewals to the spring?
So there are no renewals. They have to be.
That's my fault.
Well, but no, I'm saying it's a big deal because on their side, actually processing them as, because the 1 year ones that got funded, which were technically spring 25, are just now dollar saving accounts now. And so there's a timeline that gets built in to actually make it happen. And so I don't want to say, well, turn around and submit us your outcomes when you've been doing the project for this year. I was just my own thought about it.
So they're just getting money now, and then spring meetings, the spring meetings access.
I joke, it's Houston spring, you know.
Okay, but I think that's a fair point. So they won't have that many.
And to be extra clear, no one's been reimbursed yet for a spring court grant. We've only executed 24 of the 109 grants. And we got our first reimbursement request, which will take we will scrub very carefully. We just got our first 2 this week. So a spring grant means a very long period to get, because we're doing this very carefully.
Okay. Can I throw another wrench? Do we have to go and vote on the full grant cycle today? Can we just vote on spring? And then come back as we move forward on what is happening with the short term, what is happening with our next one? Say, okay, here's what we're seeing, this is what's happening. Let's now do the rest of the.
You don't have to. It would be nice to have at least a framework or a skeleton.
Okay.
But
there's a lot happening that still has to happen in
Absolutely.
2025, and I hate to make a decision that, or I guess we could do a framework and then do an amendment to our framework potentially.
And you did that last time. You
Yeah.
adopted a grant plan in January.
Yeah.
Then you came back in April and refined it, and you
Yeah.
swapped the years and picked your targeted strategy.
If we have, what I think we've all kind of tentatively talked about is having a combination, one big core, $75 million, that's as broad as the framework can be. And we can say special consideration will be given to topic 1, topic 2. But having a core that's approved, 75 million in total, that's gonna happen late summer, early fall, that is, and 3 to 5 years, that's broad. I think we could possibly want it, and then we have to provide the one thing is not in here, but I think the numbers group has to weigh in on is the size per application. The maximum size per application, because I can see that.
For the fall, it's 250 per year per.
And that is one thing you could remove and then just let one of the working groups weigh in on it as we refine the NOFA.
Yeah.
And, to some of the points I forget we raised it on the WebEx here, is having this a larger number of smaller awards checks for staff. But as far as getting more rural areas involved, I think opens up opportunities to move away from some of these large applicants and ensure that we have more of the money going to more of the state.
And that's the whole principle of having the regional grants, yeah. Is there a motion?
Do you want me to?
Please.
Make a new motion? All right, new motion. Sure. All right. I move to keep the spring 2026 topic, but amend the scope from statewide to targeted with a narrow focus, and the stakeholders to be have this discussion with will be key healthcare providers from the state prisons and major county jails. Also, the summer 2026 call will be removed and combined with fall 2026. This would make fall 2026 have a regional grant strategy that is open to all categories with preference for programs addressing pregnant and postpartum women, and as well as MOUD expansion. I also would move to have the timelines changed to 3 to 5 years, and remove the $250,000 cap per project per year that's currently listed in fall 2025. 2026.
I like all of it. I just like I add one amendment. Is not just the major county jails, but also the rural public health and jail facilities that manage into the first part on the prison jail, the spring session.
I would add, and I would request that we keep the focus area bullets that are currently in fall to expand upon laid out as far as the focus areas.
We can have a lot of detail in the actual note. What work group you does the note?
I'll second that.
And before we do the vote, to clarify, the way it's currently set up, the Futures Working Group, looks at the NOFAs, to make sure that we're on track before we publish them. The other thing, we'll have to huddle to see what exactly this looks like for the spring, if that's gonna be a NOFA, or if we're just gonna call people and say, congratulations, we want you to take some of our grant money. And then the last clarification is, we're gonna, if you vote yes on this motion, we will take these notes back, I roll them into the draft you have in front of you. And then we will probably send it to the Futures Group to get their sign off before we publish it as the adopted grant plan. Does that sound? Okay. Does all that sound good before we take a vote?
I think we all should be made aware of what is happening as you go through this process.
Yeah, each working group maybe.
You want every group to weigh in on it?
Yeah, I think so. Or
Yes.
Are we allowed, am I allowed to email it if there's not? Okay, great, I'll email all of you.
Point of clarification, I didn't say it but I wanted to be clear that reapplications of currently funded projects would be allowed as part of that fall, but I mean, it's a reapplication, so it doesn't need to be listed specifically, but maybe that's part of the note. We could call that out. But also everyone ardently listening, to us go back and forth, I'm sure is those of you who are not asleep.
Any other clarifications or questions before we do the vote?
Yeah, I'm sorry. I think this is irrelevant, but I just want to say that I want to make sure that all these programs submit some type of thing on their effectiveness, their challenges, what they do differently or want to do differently on not just at the end of the project, but as an ongoing update on how they're getting their money. And I think we really need to, and I know I'm the numbers group, so to speak, but we really need to have some type of uniform outcome measures. You know, we're starting all these different things. We're throwing all this stuff out there. But I think, you know, it's probably needs to be everybody in the council and not just our limited work group to look at, you know, what are the outcome measures? 'Cause clearly it's overdoses, you know, but is it ED visits? Is it patient satisfaction? Is it, jail or recidivism? Is it sustainability? I mean, we need to have something in here to start thinking about this. I mean, we're gonna have money, but again, you know, I'm just worried always that we can potentially have all the best intentions and we either don't move the needle or we move the needle in the wrong direction. And so I think we need to do that just because we're still, believe it or not, 30 years into this fight against opiates, we're still in uncharted territory. And we're throwing out a lot of money, and if we do this right, we're gonna be the model for every other state in the country, and that's how I like to play it, rather than being the ones that we look at, oh, look what they did in Texas. I don't wanna be that, I wanna be like, wow, look what they did in Texas, let's make this the model. So I think if we have outcome measures, that needs to be very well thought out with this entire group, because there's clear expertise around this table that is, including from your office, on what's easy to measure, what's not easy to measure, what's easy to calculate, or what aren't we measuring?
I think that's up to us as a subcommittee to have prepared before the fall of 26. NOFA goes out, so we can be very prescriptive.
Anything else online before we do the vote?
I'd like to just point of order to probably divide the question. There was a lot of motions in that one motion. And I think probably if we could just, I think I heard 3 separate motions out of all that. So I think divide that question up so we can be clear about what we're voting on.
Do we do one motion in the spring? What do you want?
I do one in the spring, one in the fall.
Okay, Dr. Gordon.
Okay. Number 1, I move to change the scope of spring 2026 from a statewide to a targeted strategy with the same budget. The stakeholders that will need to be contacted will be key healthcare providers for the state prisons and county jails.
County jails, just all county, just.
And whatever other public health entities may be associated with that.
And associated health entities.
All right, members, you've heard the motion.
Second.
Dr. Yupa. All right, let's take a vote on this one, right?
Or is there any more discussion, I guess, first?
On this
No,
first
no
amendment.
more discussion. On the first-
No.
On the first motion,
Members, please unmute yourselves. We will do this by a voice vote. All those in favor, say aye.
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 All those opposed, say no. Any members abstaining? Right, so, there being 12 aye votes, 0 no votes, and 0 members abstaining, the motion passes. All right. Move on to the next amendment on the 2026 grant issuance fund.
Right. The second motion that I would like to make is to remove the summer 2026 and combine it with the fall 2026, making one regional grant strategy core opportunity that has a total of $75 million. This will be open to all categories with special interest for pregnant and postpartum projects that focus on pregnant and postpartum women and for MOUD expansion. This is also open to reapplications of currently funded projects. This updated fall 2026 fall will also have a change of grant terms from 1 to 3 years to 3 to 5 years. And the cap on the award that is not to exceed 250,000 should be removed.
One point of discussion on this section, thinking about it. Is there any utility of separating out reapplications from the new core grants? Can those both happen in the fall? The reason I ask is that I think folks who have already applied will have a leg up in real time versus new applicants, since they've already generated applications in the past that have been successful. So I want to make sure, again, now that there's no cap, that the money is equally distributed across the state. So I'd like to hear from other folks what they think about this, or if there are concerns.
I kind of like what he said to say. I think there should, I mean, I'm not sure how many different regions we have across the state. 20. So there should be a minimum of one for every one of those regions.
We're in the 1 year.
Yeah, but that's what I'm saying. That's maybe that's quite your issue.
Well,
That's already required in state law in.
Okay, perfect. Then we're already done.
I think your concern is that the scope of the projects could be biased towards reapplications. I think my understanding based on discussion is we can address that in the actual NOFA to give, whether it's just a narrative preference or an active scoring preference to applications in our property areas. So that's probably your all's work group to finalize.
And as it gets closer, there's a lot we have to figure out about targeting this and how to apply, but when it gets closer, we might decide maybe we issue 2 NOFAs at the same time. And maybe one NOFA has X amount of dollars available, and the other NOFA has everything else. But then when you start having smaller dollar amounts, then you get into the 20 regional breakdown each year. So that's a really good point for now. Maybe we just adopt it as is, and then we have several meetings to make amendments.
Okay, so to make sure I understand, if we adopt this is today, we have the opportunity to chunk it up in different ways in the future.
Yes, we can always come back and amend the grant issuance plan. Yes. And when I say as is, I mean as stuff is important. Yes, Ethan.
Also, if we're going to remove the cap, we do have consideration about not having only one grantee receive all the funds. So that maybe we need to put in, they can't get more than half the funds or something, to ensure that we have enough for at least.
So it has 50% total regions already there.
So just keep that.
Yeah, I just removed the $250,000 half of it.
Right.
All right, members, you heard the motion by Dr. Thornton. Is there a second?
Second.
Dr. Mills, members, please unmute yourselves and we'll do a voice vote on this motion. All those in favor say aye.
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 All those opposed say no. Those abstaining? There being 12 aye votes, 0 no votes, and 0 members abstaining, the motion passes.
All right, just a very little bit more to cover. Thank you, everybody. This was really helpful discussion. And this whole group is the Futures Working Group. So, item 5 on the agenda is reports from the newly organized work groups. We've heard a lot from the Futures Group. If anyone wants to add anything. Dr. Thornton, you want to report back from the Numbers Working Group?
Sure. Yeah, thank you. Thank you all members of the Numbers Working Group. So we met 3 times this quarter, November 4th, November 25th, and December 8th. And our 2 major areas of work are 1, evaluating and reporting, and 2, financial planning for these opioid settlement funds. So on the evaluation reporting side, we reviewed how other states, including North Carolina, Tennessee, and Colorado, structure their metrics, dashboards, and reporting requirements. Building from these examples, but really making Texas excellent as our goal, the working group, began developing a common library of metrics that could be used to serve as a standardized framework for grantee reporting in Texas. We also discussed the possibility of allowing grantee defined objectives that the council could then approve, similar to the Tennessee model. Staff compiled example metrics and templates to support this work. It is a heavy lift on the staff as well as working group to make sure that this library is well justified, flexible enough to allow implementation, but also rigorous enough to do the strong evaluation we need. Also, we received a briefing from the Texas Overdose Data to Action Group, which is a statewide partnership between DSHS and the CDC. They provide an overview of their surveillance, evaluation, and reporting infrastructure, helping us identify opportunities for alignment and avoidance of duplicative reporting. On the financial planning side, the work group reviewed updated projections of total anticipated settlement dollars and analyzed several spending scenarios, including models with and without an endowment structure depending on program duration. We also discussed the 26 grant issuance plan allocations and previewed potential Tableau-based dashboard for public-facing financial transparency. And so together, the council as a whole, our work group working with the council as a whole, we want to make evidence-informed decisions about both the long-term stewardship of settlement funds and the measurement of outcomes across funded initiatives.
Dr. Mills, Dr. Wilkes, and Dr. Keebler are also on that working group. Anything you want to add?
All said.
Yeah, well,
Well said.
Agree.
And I want to give Nolan a shout out. He's our numbers guy, so thank you to him for doing a lot of that work. Dr. Milton, do you want to report for the currents group? That's yourself, Dr. Louise, and Dr. Fernandez.
Yes, hello, everybody. Yeah, a few notes here. The Currents Working Group met on November 6th and December 8th. The scope of this group is to monitor active grantees and ongoing activities. This may include monitoring active grantees and gathering process updates, advise the staff on grant amendments and adjustments, participate in roundtables and public engagement events, and advise on peer review methodology. In 2025, we met with 26 unique groups, including 10 vendors, 9 community-based organizations and/or providers, and 4 higher education or policy institutions, as well as 3 Texas government entities, both state and local. Roundtable surveys occurred on March the 5th, June the 4th, and October the 8th, each with a council member in attendance. I attended the one in October. The feedback and comments concerning the format and contents have been positive. Some of the needs that participants noted included increased treatment services, linkage to care, prevention, education, and treatment, justice-involved populations, workforce development, housing, and others such as stigma and long-term recovery. And so in summary, that's we've been actively engaged and productive this year, and we hope to be so in the future as well. Thank you.
Anyone else have anything to add? And I do want to, Lydia had to miss the first currents working group meeting, but all those meetings Dr. Milton listed, Lydia was in all of them. So she's our stakeholder face. Thank you very much. Next, we'll move on to the financial report. It's on page 30. There's a memo reflecting the revenues, expenditures, and balances for each of the accounts. Table on the screen summarizes the balances and highlights the large expenditures. The first line, this is the trust fund. This is the account that the council has authority to spend on grant reimbursements and hospital district distributions. As of a few minutes ago, you have now obligated $260 million of that amount to grant issuance plans, and only $1 million of that has actually been reimbursed to our grantees. The trust fund earned an additional $5.8 million in interest since you saw this memo in September. Another thing to point out related to finances, just last week, we sent the legislature the statutorily required financial summary of program expenditures in fiscal year 25. And we shared that memo with the numbers working group, and we're happy to share it with anyone else if they're interested. Any questions or concerns about the state of finances?
Can you share that memo with me?
Absolutely.
And then I just want to comment that I appreciate, the release of funds back in March for the cities and counties. We often get calls from them, and so I appreciate that they all are keeping updated on that and everything. That was a good distribution for them and the 44 million.
Great. We're actually meeting on Friday with the Texas Association of Counties.
Great.
So we're building relationships all the time. Great. If it pleases the chair, I'll move on to what staff has been up to. We've already talked about a lot of this. Of the 109 short-term grants that you awarded in September, 24 have been executed. One has submitted a status report. The other 23 are due at the end of this week. Their very first status report. 2 have requested reimbursements, and we will start looking at those. We are almost ready to release the long-term core NOFA. We've learned a lot from the short-term core NOFA, so we're working on multiple how-to videos so people can be a little bit more deliberate with how they fill out their budgets, and kind of learn our system a little bit better. I'm very thrilled with how this reorganization of the working groups has worked out. I like getting more time and participation from y'all. We've onboarded 2 new council members. We're very happy to have you. Thank you. We published a new hospital district distribution dashboard, which includes both allocations for the hospital districts. We held a fall roundtable that Dr. Milton mentioned on October 8th. Dr. Milton was there, as well as Texas A&M Health. They gave a good presentation about their TOPS program that the council funded as their K-12 prevention education grant. And then in January, this is a big deal. We will be sending out instructions to all political subdivisions and hospital districts about how to report on how they spent their funds in calendar year 25. Because one of the many settlements does require that we report back on how settlement funds are spent. So Nolan is our point person on that. We're keeping, everyone should be on alert that this will be coming. And we're working on making this as painless as possible. And then the last thing I'll point out is that one of our grant specialists, Audrey Bradshaw, is retiring at the end of this month, and we are in the process of hiring 2 new grant specialists because our program is growing fast. Are there any questions?
Yeah.
Anything to add?
So the settlement requirement that these groups have to report, that is going to expire after this year, or is that continue for a fixed amount of time?
Use it until the money is good.
Okay, good. Good, okay.
And the state has to report to NOAA, and so we in turn have to ask the entities that receive the funds how they spent it.
Well, we don't award entities money only from this kind of.
Oh, correct. It's a big pot.
Good, good. That's on our benefit.
Okay. Agenda number 8 is the next meeting. We'll do that in a few months, both here in the room and on WebEx, depending upon the long-term core NOFA and a few other things. Is there anything else?
Appreciate the team's work, comptroller's team. Okay. A lot of work.
All right, members, thank you for joining. Do we have a motion to adjourn?
Motion to adjourn.
Dr. Oluwase, is there a second?
Second.
Members, at this time, please turn on your cameras and unmute yourselves for voice vote. All those in favor say aye.
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 All those opposed say no. Those abstaining. There being 12 ayes, zero no's, and zero members abstaining. The motion passes. Thank you for your attendance. Basically, the meeting of the Texas Opioid Abatement Council is adjourned at 12:05 p.m.